Sure, it's amazing.
I didn't. Want to get started? Yeah.
No.
Hey, everybody, welcome, and thanks for attending. This is our third, I believe we're cruising along, our third research grant rounds here in the College of Health Sciences. Thank you all for being here. Probably don't need the microphone, but for folks on Zoom, I think they need this so they can hear me. So I'm very excited to introduce here our third speaker in our series, Dr. Nate Williams. Dr. Nate Williams is an associate professor of the School of Social Work here at Boise State University. He's also the Boise State University Foundation Board Endowed Professor of Health Sciences and a licensed clinical social work here in the state of Idaho. As an implementation scientist, Dr. Williams' work focuses on improving the uptake and delivery of evidence-based practices in mental health settings that serve youth. He has substantive experience in organizational culture, climate, and leadership, and methodological experience in the design of hybrid effectiveness implementation trials and testing the mechanisms that explain how implementation strategies work. Dr. Williams is deeply committed to partnered research that generates meaningful improvements in human well-being, and his work has been funded by the United States National Institutes of Mental Health, the U.S. Institution of Education Sciences, and the state of Idaho. So please join me in giving a warm welcome to Dr. Nate Williams.
Well, that was very impressive. I hope I live up to it today. I'm excited to talk with you all about some research that we've been doing in my lab focused on implementing evidence-based practices in children's mental health settings. So, title of the talk today, GPT gets an assist for trying to inject some drama into this title. Why evidence-based practices fail and what we can do about it. Leadership, organizations, and the science of making care work in the real world. So before we get, oh, by the way, Gemini gets an assist for making this cool graphic for me. 2 wins for AI. So before we get started, I'm a social worker, so I was trained very clearly. Always start where the client is. You all are not my clients, thankfully, but we are going to go on a journey together. So I want to get a little temperature check in the room. So I'm going to ask for a show of hands on 2 quick questions. First question is, if I say evidence-based practice, do you know what that means? And I'm not like, we're not having a big epistemological debate, but like just if I say that term, do you generally know what that means? So let me just see a quick show of hands. People know what evidence-based practice. Good, excellent. Everyone knows what I mean. A little harder question maybe. Implementation science. How many people feel like they're really familiar? They know it. If I give you a primer, you're gonna be kind of bored. Okay, like a few. Okay, good. That's good because I'm going to give you a little primer on it. So those of you that raise your hands, you can check my work and tell me after how I did. But the rest of you, you're just not going to know. So okay. So my work. So let's dive into what my work focuses on. As Mike said, I'm an implementation researcher. So my work focuses all on this big implementation gap right here. And when we talk about an implementation gap, what do I mean? Well, what I mean is, the United States every year, and many other countries every year, invest literally billions of dollars in health research. And so we've got like all this great research going on over here. And the goal of all that great research is to develop treatments that actually make people better, that cure people's diseases and disorders that they're facing. And so when we do all that research, something really cool happens down here at this little left panel with all the cute little smiley faces. We actually develop treatments that work, and we know that these treatments work because we've tested them in rigorous trials, and they make people better. And we're really excited because we've engaged in this scientific process of discovery, and we found something that's excellent and is going to make the world a better place. And then something kind of sad happens. When we go over here and we look at the care that's being delivered in all of our real-world clinics, all of our routine care settings, we see that all these cool smiley faces that we made are not getting delivered as much as we would hope in these real world settings. Or sometimes they're being delivered, but like in this weird way that's really not aligned with how they actually need to be delivered to produce some kind of a positive effect. And so what we have then is this implementation gap. And what implementation science argues, hello?
One behind the curtain.
Okay, what I didn't prepare for that. But it's good. Thank you for coming. So what implementation science argues is that in modern healthcare, the big bottleneck we have isn't discovery. Like, we know a lot about what to do to make people better. It's, yeah, we should keep doing that work. That's important and good. But the big bottleneck we have is delivery. How do we get these things, these evidence-based practices that we actually know work? How do we actually get them into routine care settings? And so that's what my research focuses on, is how do we span that implementation gap? So that's all kind of high level and abstract. Let me make this very, very concrete and talk about a specific evidence-based practice that my trial that I did, that I'm going to share with you today, focused on. So within mental health services, and I focus on mental health services research, I focus specifically on children's mental health research because I was a therapist working with children and families many, many years ago. And so within that area of care, there is an evidence-based practice called measurement-based care. And as the name suggests, what measurement-based care entails is when you get a new patient that comes in to see you for mental health services, you're going to see this patient weekly for psychotherapy sessions or whatever. When they come in at that first visit, you administer a standardized symptom rating scale and get a valid and accurate snapshot of where they're at, right? And then every session that they come in after that, you administer the same scale again, so that you can see over time, how are they progressing? Are they getting better? Is what we're doing working, or are things not really working out and I need to change out what I'm doing? Now, if you don't know anything about mental health treatment, you're probably thinking, wait, that's an evidence-based practice? Isn't that just what you should sort of normally do? But the answer is no, that's not how mental health treatment has been delivered historically. And so when someone came up with this idea, it was like, oh, that's an innovative idea. And so we now have dozens and dozens of randomized controlled trials that show when clinicians get this type of feedback, this standardized feedback on how their client's doing over time, their clients get significantly better than the clinicians who did not get this kind of feedback over time. We also know that this feedback is especially beneficial for the patients who are the most likely to not get better, right? You've got people, when they come in for therapy, they're not going to get better. Things aren't going to get much better for them. And if you give therapists this type of feedback, those are the people who benefit the most from their clinician getting that type of feedback. So it's actually helping the most vulnerable populations the best. So this is a great evidence-based practice in mental health settings. It applies across diagnoses. It applies across treatment modalities. It's basically like an awesome thing that everyone should do. And sadly, and unfortunately, very few people do it. It very rarely happens. And what happens sometimes is it gets mandated, and this is really important. When it gets mandated, what do you think happens? It gets implemented very superficially. So measures get passed out to the patients, and the patients will do them-ish, mostly, right? But guess what? The clinicians never even look at the feedback. So you're basically, what you've done is you've increased paperwork burden on your patient population, and you're not improving their care at all. And so this is definitely a significant implementation problem. And so when we talk about the implementation gap, this is the kind of gap that we're talking about. And the trial I'm going to share with you today address this gap. I'm going to try to advance my slide. Oh, there we go. So in implementation science, we are addressing this question. If we already know that it works, why doesn't it happen? And when you look at implementation research literature, you're going to see basically two different kinds of studies. The first kind of study looks at barriers and facilitators to getting a specific evidence-based practice implemented. So they're going in and they're studying, or when someone's trying to implement a new evidence-based practice, they're saying, what's getting in the way here? What are the barriers? What are facilitators? And when they do that assessment, it's a multi-level assessment, because what we know is that barriers to getting new practices implemented don't only occur in the clinician, right? If I'm a clinician, it might be about my knowledge. Like, I might lack knowledge about that this thing even exists or how to do it, right? It might be about my motivation level. But we also know that the care that's delivered is influenced by the context within which that care is delivered. So what's the culture of the agency that clinician works in? When they go in, they have to respond to the culture of that organization and the priorities of that organization. What's that look like for that clinician? What's the reimbursement and the policy environment look like with regard to that practice? So we're taking a multi-level snapshot of what are the barriers and facilitators to implementing specific evidence-based practices. That's one kind of study you'll see in implementation science. The second kind of study you'll see, which is what we're going to talk about today, are trials. And these are trials that are testing out different implementation strategies. And an implementation strategy is basically an intervention that's designed to improve the delivery of some evidence-based practice. And so the randomized trial is about, can we improve the delivery of this practice? I think on my next slide, I say, oh, maybe. Oh, okay. So implementation science is the study of how to make evidence-based practices happen in routine care. And the point that I was going to get to is on the next slide. If I can advance my slides. There we go. So a lot of us are used to thinking about clinical research, and it's helpful to understand implementation research to contrast it with clinical research. So in our clinical research paradigm, we're asking, does this treatment work, right? I want to develop a treatment for depression. And I want to find out, does this treatment protocol that I've developed for depression, does it actually reduce depression? That's what I'm focused on. And so that's my treatment question. One of the important things about answering that question is that anytime I deliver my treatment, it's going to be delivered in some kind of a context, in some kind of a care context. So when we develop treatments, we have two kinds of trials we do. First is efficacy trials. In an efficacy trial, we become experimental maniacs and we try to control everything and control the daylights out of the context so that we can just very precisely isolate, did my specific procedures to treat depression actually improve depression? Take away all this extraneous stuff. So we're trying to tightly control that context in our efficacy trial. Then if we get really bold, we go into an effectiveness trial, or some people call it pragmatic trial. And we say, all right, now I'm going to test my cool treatment for depression in a real world clinic. And now there's context there, and I'm going to let go of my control issues and not try to control it. But now I'm just tolerating that context. It's a nuisance, it's annoying, it's probably going to create problems, but I'm just tolerating it. But all I really care about is, did my treatment work? Did it make people have less depression symptoms? In implementation research, we're asking a totally different set of questions. We're no longer asking, did the treatment work? We're going to take for granted that the treatment does work, that this is something that should be done. And what we're asking now is, how do you get that treatment to actually be delivered in the way it's intended to be delivered and sustained over time? So we can still do an experimental trial of implementation strategies, but the goal of those strategies is to get people to do these evidence-based practices in the right way over time. We're no longer testing if the evidence-based practice is effective. The other big difference with implementation research has to do with context, because when people deliver care, it's in a context, and in implementation science, we're not going to ignore or just sort of tolerate that context. We're going to attack it. We're going to try to modify it. We're going to say, what can we do with this context so that we can make it more likely that people will deliver this intervention in the way that it's intended to be delivered? So those are some of the big differences between implementation and clinical research. Oh, my slides advanced for me. That's good. Did they only advance once or multiple? Just once. Okay, good. So since we have different research questions in implementation science, we have different outcomes that we're interested in, right? So in clinical research, we're interested primarily in symptoms and functioning. Did patient symptoms and functioning get better? In implementation research, and there's taxonomies of implementation research, I'm not going to take you all down that road, but this is sort of a sampling of the kinds of outcomes we look at in implementation research. Things like adoption. Did clinicians actually start trying to use this practice? Maybe they're not using it perfectly, but they started. They said, all right, I'm going to do this, and they're trying to do it. We look at things like fidelity, which we're going to look at in the trial today. Was the treatment actually delivered in the way it's intended to be delivered, right? That's the fidelity piece. Sustainment, does it last over time? We're going to look at sustainment as well in the work that we're going to look at today in the trial. And then uptake and reach is more of a population level outcome. So like there's all these patients that get served by this clinic, sort of what proportion or what number of those patients actually were exposed to this intervention, right? I can deliver this evidence-based practice to only 2 people in my clinic, or out of the 500 people I serve, I can deliver it to 450 people in my clinic, right? So that's this idea of reach or uptake, and we're going to look at that in our trial today as well. So last thing I need to tell you before you get your graduate certificate in implementation science is that when we design and test implementation strategies, just like when we design clinical interventions, those strategies target specific mechanisms that we think are important for changing clinician behavior. Usually that's what we're trying to do, is change clinician behavior, right? So we're going to design a strategy that we think activates specific mechanisms, which then in turn change clinicians' behavior with regard to the evidence-based practice, which then in turn is going to improve patient health outcomes. So we're going to see a mechanistic focus. It wasn't always like this in implementation science. When it started, people just randomly did things and said, I don't know how to get people to do this. Let's just try that, okay? And it wasn't super scientific, and it wasn't as productive as it could have been. So now we know, no, we need to specify the mechanisms that we're targeting, and we need to test those out. And we're going to see an example of that in the trial today. So Congratulations. You all now have your graduate certificates in implementation science. I'll sign them for you after the session. So now that you got all that background, I'm going to tell you about a trial that I led, which we lovingly call the Wisdom Trial, which stands for Working to Implement and Sustain Digital Outcome Measures. I did not, this is an NIMH-funded R1 trial. I did not know before doing this trial that you need to have an acronym and you need a logo. But my senior co-investigators informed me that these are very important components. And so we developed, I think, a great acronym. And this logo was designed by the project coordinator for my study. So not only was she like basically doing all the work, she even designed a logo for us. Nayeli Vega, she's no longer here. She went to Oregon Health Science University. But anyway, so I got to give her credit for that. But this is our trial. It's an implementation trial testing out implementation strategies to try and improve the delivery of digital measurement-based care. So you already know what measurement-based care is, I told you. What I haven't told you is what digital measurement-based care is. So this is an important nuance, actually. I told you earlier, measurement-based care means every time your patient comes in, they fill out a standardized measure, you score it, you look at how they're doing over time. If you're a clinician, that sounds very burdensome and annoying, doesn't it? Every time I gotta waste the precious limited clinical time I have on scoring this measure and trying to make a little graph, right? So early on with measurement-based care, that was a major implementation barrier. Well, that barrier got fixed like 20 years ago by digital measurement-based care systems, which take the whole measurement-based care process and now it's all on a computer. So the patient literally can complete the measure before their visit on a tablet in the waiting room or on their smartphone before they even get there. It gets instantly scored by the computer and the computer spits out a cool little graph and it'll even highlight like any high risk items. Hey, this person endorsed this item and that's a red flag item. You better ask them about this during the session. The most sophisticated digital measurement-based care systems are even better than that. They actually add clinically valuable information to the picture because what they can do is based on big data actuarial algorithms, based on data from hundreds of thousands of patients, they can predict with a very high degree of likelihood, as they monitor a patient's progress over time, they can predict, is this patient on track? They're getting better, keep doing what you're doing, good job. Or has this patient gotten so far off track that I'm gonna throw a red alert and I'm gonna tell you, clinician, this person's not getting better. It's highly accurate. It's very likely that this person ain't getting better if you keep doing what you're doing. In fact, there's a good chance they'll drop out and you'll never see them again, which happens a lot in mental health treatment. So what these systems do is not only let you track the scores over time and stuff like that, but they'll give you this additional clinical information about whether what you're doing is working or not working. And so they're really, really beneficial. There's also evidence that measurement-based care like this is actually, it's beneficial for adults and kids, but there's evidence it's even more beneficial for kids. But it almost never happens with kids. It sometimes happens with adults and almost never happens with kids. So we said, let's do a trial to try to get digital measurement-based care to be implemented in outpatient mental health clinics. So that's what we did. So the first thing we did was we jump in the literature and we say, what are the barriers and facilitators to implementing digital measurement-based care in mental health clinics? And when we dove into that literature, something interesting happened. What we found is that there was barriers and facilitators at different levels, but the most prominent ones, the strongest and most consistent predictors of whether or not this was happening had to do with the practice setting, had to do with the organization where the clinician worked. That was really what was driving whether or not people are actually doing this. And when you drill down on that, you get into issues like, is there leadership in that clinic that's really championing this and that's able to support clinicians to implement measurement-based care? Is there a culture and a climate within that clinic that really values and supports the use of patient data to do things better? And are there policies and procedures to kind of sustain over time? One of the big issues in mental health settings is there's a lot of turnover. I don't know how it is in nursing or other places, but in mental health, there's a lot of turnover. And so you need some organizational policies and procedures in place that as new people come in, you can get them up to speed and you can keep the measurement-based care train going. So this is what we saw in the literature. We also saw in the literature that there was only one trial testing different implementation strategies to try to improve measurement-based care in mental health settings. Only one trial, so that's a big opportunity for us. And that trial tested two different ways to train clinicians. So it wasn't even focused on these organizational issues that we thought were so important. So we said, oh, this is a great opportunity. Let's do a trial where we test an organizationally focused, a leadership focused implementation strategy to see if it can actually improve the delivery of digital measurement-based care. Okay, everybody with me? All right, good. We're doing good. So here's the logic that we tested. We said, we're gonna get ourselves an organizational implementation strategy, which I'll tell you about in a minute. It's gonna focus primarily on leadership within these mental health clinics. And what it's gonna do is two things. First, it's gonna support leaders within these clinics to develop implementation leadership skills. The leadership literature is vast. And within that literature, there's a specific type of focused leadership called implementation leadership, which is all about, do you as a leader have the skills to help other people implement something new that's coming in, like digital measurement-based care? So we wanted to focus on that. One of the things that happens in mental health settings, and I'm interested if this happens in other clinical areas as well, is who are the people that are leading mental health clinics? Oftentimes, it's people who started as clinicians, did a good job, and stuck around for a long time. And if you do meet those criteria, you get promoted up into leadership roles, which is great because you have a lot of great clinical skills and expertise and all kinds of other skills too. And you have longevity and you're reliable, so we really like you. But what that also means a lot of times is that you haven't necessarily been trained in like leadership skills and how do you organizational change, how do you lead the implementation of a new digital health technology? Like there's a lot of leadership stuff that people don't necessarily have. And so we thought that that was an important piece to address in our implementation strategy. So we wanted to improve implementation leadership in our clinics. We also wanted to improve something called implementation climate. Now, the literature on organizational culture and climate is also vast. Within that literature, there's a type of climate called focused implementation climate. And what that means is this. When you go into a new place to work, most of us do, what I do, is you look around and you observe what's the policies and the procedures around here, what's everybody doing, what's my boss telling me, and I talk to my colleagues, and I try to get a sense of what really matters around here, what's really important, what do I actually have to do, because my boss is going to bring it up in my annual review, and what should I very safely ignore because nobody cares, and in fact, if I do that, people probably get annoyed at me, right, sometimes. So that's what with a focused implementation climate, what it is it exists when the clinicians within an organization all have kind of come to share this belief that implementing this new thing, it really is a priority. I actually need to pay attention to this. I need to figure out how to do it and do it well. It's really something that matters here. As opposed to, oh, here comes this annoying new thing. I think I'm going to ignore that and it'll just go away in a couple of weeks. So an implementation climate is where people really know that it's prioritized. And they get that sense by observing the policies and procedures within the organization and hearing from leadership. So we wanted to attack these two mechanisms. And what we believed was that if we improved implementation leadership and climate, that then is going to change clinicians' behavior, make them deliver digital measurement-based care better. And in terms of measurement, we measured it at the youth level. So it's like, yeah, you can measure clinician behavior, but we wanted to know, are the kids coming into these clinics actually experiencing different care because of the strategy we're doing? Are we actually changing what is happening to these kids and their families, right? So so we were measuring, our primary outcome was fidelity to measurement-based care at the youth level. And then we also thought that if we can improve fidelity, we'll improve youth symptoms. The kids will get better if they get more measurement-based care. So that's what we're testing. Everybody got that? Okay. There we go. I'm getting better on my zooming in and zooming out for presenting my slide. I'm learning. I'm engaging in this isn't organizational learning. This is individual learning. Okay. So the strategy that we tested is called LOCI, or Leadership and Organizational Change for Implementation. It was developed by some of our colleagues who were co-investigators on this grant at the University of California, San Diego, and the University of Central Florida. LOCI is a 12-month organizational implementation strategy, so it lasts 12 months, and it has 3 parts. There's how it unfolded in our trial over 12 months, and I'm going to tell you about the 3 parts. Okay, the first part is leadership training that we do. So we have quarterly leadership trainings, and these trainings focused on what we call first-level leaders. First-level leaders are the ones who are directly supervising the clinicians. So these aren't the executive leaders, these are the ones supervising clinicians. And so for those leaders, we do a quarterly training, teaching them these implementation leadership skills. And then in between the quarterly trainings, they have brief weekly coaching calls. So they have a call, like a 15-minute call once a week with the LOCI coach, because what they do at the beginning is they create a leadership development plan, and that coaching is to help them kind of keep their motivation and keep their progress going on their leadership development plan. Once a month, we switch out their individual coaching with a group coaching call where we bring together all the leaders who are in the loci group and they can kind of share strategies and learn from each other. The second piece of loci, oh, no, don't begin to the third piece. All right, the second piece of loci are monthly organizational strategy meetings. So these are like 1 hour meetings, happen once a month. These meetings include all the levels of leadership. So we have our first level leaders that we're training. We also then bring in the executive leaders in that clinic. And the goal of this is to create alignment across levels. We want all the leaders saying the same thing. We all know how important that is. So we want the leaders saying the same thing. And we want to give that leadership team an opportunity to think together about what are the organizational policies, procedures, and practices we can put in place to help create that implementation climate that I said was so important. So first level leaders can do a lot to create an implementation climate, but they really need that executive leadership to also get on board and think bigger picture, like what are we going to do as an organization to create this implementation climate? So that's what they do there. And then the third piece of loci is quarterly data. So we actually collect data from the clinicians. We ask the clinicians, and people are getting surprised when I say this, I don't care about the opinions of the leaders at all. I only care about the opinions of the clinicians because they're the ones delivering care. And so we ask the clinicians, what's the implementation leadership look like in your clinic? Like, evaluate it for us. What's the implementation climate look like in your clinic? Evaluate it for us. Tell us how it's going. And then we take that data and we feed that back to the leadership team so they can use it to develop their strategies. So that's loci. So you all are learning a lot of really useful things here now. So now you know what implementation science is, and you're all experts on the loci strategy. So now I'm going to tell you about the trial that we did. So in our trial, we enrolled 21 outpatient mental health clinics that were serving youth, doing psychotherapy with kids. So 21 clinics. We had about half of our clinics were in Idaho, and the rest were in Oregon, and some were in Nevada. So we had clinics in 3 different states. And we bring them all in and we randomize them to 2 arms. We have a control arm and we have a loci. When we bring all the clinics in, they all get training and technical assistance to deliver digital measurement-based care. So we have like this specific system we use. It's a commercially available system. Those people do training. They provide technical assistance. So we brought them in. They trained all our clinicians and leaders in like a 1-day training at the beginning of the study. And then they had technical assistance that was available to everybody throughout the study period. That's like gold standard implementation. Whether it sounds like it or not, it is. So if you're in the control arm, that's all you get. That's what you get. If you're in the loci arm, you get that, plus your leaders participate in loci. So we're testing like the additive effect of loci beyond sort of the standard implementation approach. To help us look at outcomes of loci and what effects it had, we looked at data across 3 different phases. We wanted to keep this really simple. So we looked at 3 phases and multiple levels. Just kidding, I was being sarcastic about simplicity. So our primary outcomes were during this implementation phase, and this 1 to 12 months after baseline, this is when loci was happening. Remember I told you loci is a 12-month strategy? So this implementation phase is while loci is occurring. And during that phase, we looked at outcomes at the kid level, at the youth level. And so what we did is after we trained all the clinicians, new kids start coming in for services in the clinics after we did the training. We enroll those kids in our trial. Once they come in, we follow them for 6 months, regardless of whether or not they finish treatment, right? So it's a fair comparison. And so as that kid comes in and we follow them for 6 months, we're looking at 2 things. The first thing is we're looking at the level of fidelity to measurement-based care that that kid experienced. Remember I told you that's what we want to see. Here's little Johnny. Did Johnny actually experience measurement-based care in the way it's intended to be delivered? And there's 2 pieces to fidelity to measurement-based care that are really important. The first is, did Johnny or his parents complete one of these measures at every session during the 6 months? So you got to get the measures completed, right? At every session, ideally. The second and most important piece I told you earlier is, did Johnny's clinician actually look at all those feedback reports? Or did Johnny's clinician only look at the first one and then ignore the rest, right? Or did the clinician look at all of them? So we're combining those 2 pieces of information into a fidelity index for Johnny, and it ranges from 0 to 100%. So Johnny either experienced 100% fidelity to measurement-based care, which is what we hope, or he experienced 0% fidelity to measurement-based care because nobody ever administered a measure, him or his parents. So that's what we're looking at the youth level during that implementation phase. We also looked at the youth level symptom improvement. So we asked the kids' parents to fill out at baseline a symptom assessment. These are our research measures. This is not coming out of the the system. Sometimes people get confused about that, but we asked our own questions about how's Johnny doing at the beginning, and then monthly thereafter for 6 months, parents completed these symptom assessments, so we could see if the kids were going to get better in the loci clinics compared to control. So those were our primary outcomes in that implementation phase. We're going to look at those. The secondary outcomes that we looked at occurred at different levels. So one set of secondary outcomes was this implementation leadership and climate. We asked clinicians to complete surveys rating the implementation leadership and the implementation climate in their clinics. And we had them do that at baseline before loci started. And then they did it quarterly at 4 months, 8 months, and 12 months. Loci ends right here. And then we had them do one more, 18 months after baseline or 6 months after loci ended. So we kind of got a picture of how loci affected culture and climate. And then the last thing we looked at was uptake of measurement-based care. And we looked at this outcome across all 3 phases. So I'm going to show you a slide that has data for 35 months in a trial, which is amazing in my opinion. To not do my own horn, but we're going to look at that sort of population level uptake outcome about like how many kids in these clinics are actually getting exposed to this practice that we want them all to get. Okay. So 3 aims we're going to look at, kind of summarize what you said. Does loci improve youth level fidelity to measurement-based care? And does it improve youth level symptoms during that implementation phase? In aim 2, we're going to pull in that climate data and we're going to ask a mediation question. I love mediation. And we're going to ask, did loci improve the implementation climate within these clinics like we hoped it would? And did improvement in that climate actually mediate or explain the effect of loci on fidelity, if indeed it affected fidelity? Okay, so that's what we're gonna do. We actually have a bunch of other mediation questions that I don't have time to tell you about today, but if you want to know, you can ask me later. And then the third one is we're gonna look at loci's effect on uptake of measurement-based care across all 35 months, all 3 phases. So that's where we're going. How am I doing on time? Maybe on time. Okay, 15 minutes. 15 minutes, okay. All right. Whoops, go back. So here's our N1 results. Oh, there's something important I gotta tell you about the trial. I'll tell you after I tell you the results. Okay, here's our N1 results. This is the fidelity outcome, the youth level fidelity. What level of fidelity are kids experiencing? And you see, this is a very simple bar chart, folks. This is not difficult to interpret. Here's the average fidelity in loci. Here's the average in control. There's a 20 percentage point difference, which is a humongous difference, and that's wonderful. It is statistically significant, so we were very happy. So we improved fidelity to measurement-based care by all this leadership, climate stuff we were doing up here, okay? So we were very, very happy about that. Measured at this micro level with these very objective measures of whether or not it was happening. So this is great finding. What we were sad about though, is like, if you're like me, you're looking like, wow, Nate, you got 23% fidelity. Congratulations, bro. Yeah, we weren't super excited about that either. But here's the important fun fact, not fun fact that I need to tell you. 3 months after our trial started, we were so happy our trial's going, then COVID started. So like almost all of our trial was COVID affected. So that's the great thing though, that's why you do parallel arm randomized trials. So everybody gets the same historical confound and your randomization is secure. So like our causal inferences are still valid. But we do think that that larger context probably had sort of an effect, something to do with like these really low levels of fidelity that we're observing. Because all of our clinics are not only trying to implement the stuff we're asking them to do, which actually in some ways was really helpful for them in responding to COVID. So that's a whole other story. But not only were they doing that, they were, and you all know in healthcare settings, it was massive change in how you're delivering care. And so they were dealing with all that too. So really excited that we did improve fidelity by 20 percentage points. That's a lot. Okay, so what about the youth symptoms? So here you see the change in youth symptoms over time. Higher symptoms are worse, so lines going down is good. The solid orange line is the average symptom trajectory for kids in loci clinics. The dashed gray line is the average symptom trajectory for kids in control clinics. Both groups improved significantly from baseline to follow-up, which is pretty normal. But there was a significantly greater improvement in the loci group. So not only did our implementation strategy change the care that was experienced by kids, it actually changed the outcomes of the mental health services and improved those outcomes of services. So and in implementation trials, you sometimes get the first thing, you rarely get the second thing. So to have this was really exciting. The effect size here for all of you effect size aficionados is 0.31, which is small, but in youth psychotherapy research, that is a very respectable effect size. It's like the difference between usual care and like a hard, tightly controlled evidence-based treatment. So it's a good effect size in youth psychotherapy research. We got to interpret our effect sizes discipline specifically, not just with the general rules of thumb, right? Y'all agree on that. Again, we especially agree when it works in our favor. Okay, all right. Aim 2, we wanted to look at how did loci affect leadership and how did it affect climate. So here you see the average clinician ratings on implementation leadership by group. The solid orange line is loci, the dashed gray line is control. I'm very considerate of my viewers, so I always use the same line so you know what the heck is going on. So you can see at the beginning, not a lot of implementation leadership happening with regard to digital measurement-based care, which is expected. That's before we started doing anything. But then by 4 months after we kicked off loci, the implementation leadership is significantly higher in the loci group relative to control. The effect size is 1.17, which is a humongous effect size. It's one of the ones that makes you be like, let's double check our math on that. Exciting, but it seems a little too good. But it is, and that's what it was. And you can see that that effect was sustained all the way throughout. Loci ends right here. So basically we sustained the superior implementation leadership to the end. And then in our 6-month follow-up, it dips down a little, but still an effect size of 0.97, which is humongous. So really strong effects that loci improved implementation leadership of the leaders as rated by their subordinates, right? So this isn't like I'm asking leaders like, oh, did this thing help you? Do you feel pretty good now? Like this is actually asking the people there in charge of supervising data. Then the next thing we looked at was the change in implementation climate. So this is asking the clinicians about what's the implementation climate. Exact same pattern of results here. The scale's on a different scale, so the lines look a little lower. But the effect sizes are humongous, 0.98 at 4 months, and really sustained, and then dips down a little at 6-month follow-up, but still there. So loci have the anticipated effects that we hoped for. It improved implementation leadership. It improved implementation climate over time, as rated by the clinicians. So now we can ask our mediation question, which I'm really excited about. Now we know loci improved fidelity at the youth level. We know loci improved implementation climate at the clinic level. So as rated by the clinicians. So the question, the mediation question becomes, did the improvement in implementation climate mediate or explain loci's effect on fidelity, right? We've got our random assignment to loci here. We've got our change in climate over 12 months rated by clinicians here. And then we've got our youth level fidelity during that 12-month period. And so we test the mediation model, and the indirect effect, the mediated effect was statistically significant. Hooray! And the proportion mediated statistic here, does anyone know what the proportion mediated statistic is? Okay, I'll tell you. It tells you what proportion of the total effect of loci was actually explained or mediated by the mediator. So what this means, 0.71, is that 71% of loci's effect on fidelity that we saw, 71% of that effect was explained by the improvement in implementation climate. So that is suggesting that that improvement in climate was really driving that improvement that we saw in fidelity at the youth level. So that was super cool. But at least I think it's cool. Thank you all for humoring me, even if it is. Okay, trying to advance my slides. Oh, here we go. Okay, last one I got for you. How are we doing on time? You okay? Oh, good, we're good. I'm like ahead of schedule right now. Okay. Last thing we're going to look at is uptake of measurement-based care over time. Now we get to get into sustainment. We're looking across all 3 phases. And I'm going to change levels on you because this outcome variable is not at the kid level, it's not at the youth level, it's at the clinic level. So in each clinic, I'm going to go in and count the number of kids who had a measure administered to them that month. And then I'm going to go into each clinic the next month and count the number of kids that had a measure administered. I'm going to count the number of kids who had a measure administered in each clinic every month for like 35 months or almost 35 months. Okay, so for a really long time. And then I'm going to compare the difference between the loci and control groups. And so here you see the average number of kids who had a measure administered to them. In the loci group, it's the solid orange line, is the model estimated means. The little dots are the actual means. And then in the dashed line, you see the control group. And the little open circles are the observed means and the dashed line is the model estimated means. So what this is showing is that we started loci before we trained everybody in the evidence in digital measurement-based care. So like the leaders kind of had a head start. And what we hoped would happen is since we gave those leaders a head start, when we launched the system and made it available, that right away there would be higher usage of that system in those loci clinics because their leaders already got a head start to get everybody ready to go with this thing. And that's exactly what we saw right here. At 3 months after the baseline, there was a significantly higher number of measures administered per clinic on average in the loci group than there was in control. So loci helped these clinics get off to a faster start with implementing this new thing, which we know is kind of an important deal. You can see that in the loci group, it went up, up, up. Oh, that's a song. That's a popular song. It went up. Do you guys know what I'm talking about? The song, up, up, up. Okay, sorry. It went up, 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 and in the control group, it went a little bit up. But by the end of loci, it was significantly higher number of measures being administered on average per clinic in the loci group relative to control. So we have much better uptake in loci relative to control when loci conclude. So that's great. Then this cliff happens and we're very sad and our hearts fall. Okay, so obviously after loci ended, there's this big drop off. Keep in mind, they're all dealing with COVID. So when somebody's not calling you every week, making it a priority, that might have a significant effect on your behavior. But it does drop off. And by the time we get to the beginning of our sustainment phase, the literature tells you when you're supposed to start measuring sustainment, by the way, I didn't make this up. But by the time you get to the beginning of the sustainment phase, there's basically no difference between the groups. But then something interesting happens. In the loci group, it levels off. And in the control group, it goes down to here. Okay, that's a very scientific term. So when we get to the end of the trial of the observation period, uptake of measurement-based care, measured in terms of how many kids got a measure administered, was significantly higher in the loci group than it was in control. 35 months after the training and like 24 months after loci ended. So this is actually, like, you don't see a lot of data like this in implementation science. There will be more, I'm sure, in the future, but to see an effect here is actually really, really encouraging. So we have some signal that yes, loci did help sustain the administration of these measures in these clinics, even though it wasn't as good as we want. And that's kind of good, right? Because now our future research, we have some things to explore and some things to think about. So this is our first outcome we looked at for uptake, which is how many measures were administered in the clinic. But remember, I told you that's actually not the most important thing. Because remember, I told you, if you tell people you have to do this, okay, everybody starts doing it. And you can see even in the control clinics, like people started administering more measures for a while. So they kind of started doing it. But the real question is, did the clinicians actually look at the feedback? Because that's what, if a clinician's not looking at feedback from a measure, they're not using it to inform clinical care and make anything better for a kid. So basically all the measurement is useless. So this is the key thing, the key outcome is did clinicians actually look at the feedback? So here you see the number of kids who had a feedback report viewed by their clinician on average at the clinic level over time. And you see a very similar pattern of results where loci gets them off to a good start, really gets a great peak, and then it kind of crashes, but it levels off here. And we do have superior sustainment at the end. So that's a positive thing. But what I really want you to notice about this is look at the control group line. Like, right? It's a little bit up and not really, right? So what was happening in these control clinics was exactly what happens when measurement-based care implementation fails. And that is, oh, we got people administering measures, yay! But nobody is looking at the feedback. I hope you like the noises. Nobody is looking at those feedback, I see that. So this, in my mind, this is an implementation failure, like it really is in those control clinics, because even though you got measures administered, the clinicians weren't even looking at it, which means they're not using it to improve care. And so, that might explain why the kids got better in most time, not sure. So there you go. So that's the results from our trial. And it's kind of an overwhelming fire hose of information. I'm sorry, but there's multiple levels and phases and it's all exciting. So here we'll go into our takeaways and I'll wrap things up. First takeaway, leadership behavior can be changed. You can actually modify what people are doing in regards to leadership, which is good. You can equip people with skills. Changing the climate that care is delivered in can actually change the care that people experience. Changing that implementation climate actually changed what those kids experienced. and downstream resulted in superior service effectiveness. So like there's some evidence here that the context within which care is delivered really actually does matter, and it's malleable. So I'm gonna make this argument that organizational context, it's not just background noise, it is actually causally related to the outcomes of care. And this trial is providing some evidence for that. I'm also gonna argue that the problem that we addressed is not unique to measurement-based care, that similar implementation challenges exist in primary care settings, in chronic disease management, in public health, in other digital health implementation things. These kind of implementation barriers are all over the place, and there's leaders in all of these different organizations, and there's climates in all these different organizations. And so, you know, what we think is, if leadership and climate are important drivers of implementation in a mental health setting, then they might very well be important drivers in other settings too. Now, it is important to acknowledge for different settings, different practices, there can be different drivers. So we don't think like, oh, this is the magic bullet that solves all the world's problems. But we do think that it's probably something really, really important that doesn't get paid a lot of attention to and probably should be paid a lot more attention. And so bottom line, we have effective treatments, implementation is the big bottleneck. We can change leadership. It's a modifiable lever. We can change climate. And if we really want to improve the care that people experience when they go into settings, we need to treat implementation like a real scientific problem, and we need to tackle it in rigorous ways and figure out how to make things better. So that's all I got, except for my acknowledgements. And IMH funded our trial. We're very grateful and happy, and also grateful to all of our wonderful partners. 21 mental health clinics that did a trial with us in the middle of COVID. That's crazy. We wrote a separate paper about recruitment and retention, which I will not talk to you about. Yeah, that's the reason why we got that one. Anyway, that's all I got for you. Thank you.
About 10 minutes for questions, so feel free, Cheryl, if you want to start us off.
So with these, I have been exposed to these things, St. Luke's or whatever, where you get an iPad. How are you feeling today? Okay. Is there any studies that look at how many people lie on those things?
That's a good question. So the question is, do people lie on measurement-based care measures? And I don't know, Cheryl, if you're kind of confessing a personal thing with that question, but it's a good question. It's a fair question. And I cannot short-term memory access all the research in that area. What I can say is this: there literally are over 2 dozen randomized controlled trials that show when you give this feedback on those measures, however fallible they are, when you give that feedback to clinicians, the patients get significantly better on average, right? And so, as you know, to the extent that surely the measures are fallible and surely some people lie, but to the extent that that's like such a huge problem, it would negate the effectiveness of the intervention. That's the evidence suggests no, that's not true. But it is definitely the case that people lie or misrepresent. And actually, this kind of is a really important clinical point, because one of the cool things about these measures is it opens this conversation. One of the ways that they think these measures work, and I'm not an expert on the measurement-based care itself, I know a little bit about it, but is that they think that part of how this works is that sometimes people are actually willing to disclose something on a form that they really wouldn't feel comfortable saying face to face to a semi-stranger, right? Like, oh, I just met you and you're my therapist now, and I'm gonna like tell you this, but maybe I will disclose it on the form. There's been some research looking at that. But yeah, but in terms of the trials, they show that it worked. So, the other thing I was gonna say clinically, and this is relevant to kids actually, because one of the things that happens with kids is you can have a parent do the measure, or if the kid's old enough, the kid can do it, right? Or you can have them both do it. And clinically, isn't that valuable and interesting? Oh, mom said this, but Susie said that. Like, wonder what's going on here. So even in the extent where like it's not necessarily from a psychometric standpoint, maybe that's not the greatest thing, but clinically that's actually quite informative, and you're still getting information that you wouldn't necessarily get as a clinician. So that's kind of an interesting piece.
And that was my other question was, do kids answer more honestly than adults? And has anybody studied that? But you have like a built-in control if you have both kids and parents.
Yeah, there's a whole literature in psychiatric epidemiology and different things about like diagnosing mental disorders in kids, and are kids more accurate or are parents more accurate? The answer to that question, like from a psychiatric diagnostic interview schedule perspective, the answer to that question is that parents are usually more accurate about externalizing problems, which is like the kid being naughty and misbehaving, and kids are usually more accurate about internalizing problems, about I'm sad and I'm depressed, but my dad doesn't know, but I know. But if you ask me how naughty I am, oh, I'm not that bad of a kid, but ask my dad, like, oh, this kid is a turkey. So that's kind of what you get in that area of the literature. I mean, that doesn't apply to me, but I'm thinking that applies to others. Yes.
First of all, Dave, congratulations on your Endowed professorship. Fabulous presentation, like, I love this. Yeah, it kind of makes me want to be a social work major.
There you go. Me and Lynn can talk to you after this.
But my question is, what do you think about doing in the future? Like, what are your next steps? You know, you're always like,
Yeah.
1, 2, 3.
I know.
Yeah.
I kind of, this is getting a very vulnerable moment here. You know, you're supposed to write your next RO1 before the first RO1 ended. I didn't do that. Bad job, Nate. But I wrote a lot of papers. So my next step, I got a couple of irons in the fire, but what I actually proposed in the endowed professorship, because I think that's part of that question, is actually not related to organizational stuff, because I think it is related to implementation and mental health. But one of the little threads that came out in this study that was completely not related to what we did at all is that we did an early study very early on about predictors of whether or not clinicians are using measurement-based care in our own sample at baseline. And we measured something that we hadn't seen measured before, and that was, did you actually learn how to do this in graduate school? Like, has anyone actually taught you how to do this? And a lot of people said, no, not really. And that was one of the really big drivers of whether or not people were using it at baseline, before we did all of our cool work and changed all our practice. Like, that was what was happening then. And so I kind of think, and as an educator, I kind of think like, how can we as educators and as an educational institution do a better job preparing for these roles, preparing people? And so I already told you how excited I am about AI. So I'm kind of interested in like, there's these crazy new tools now that train people how to do psychotherapy using AI. And like the person does a session with a simulated client, and then their fidelity to the practice gets scored, and it's like scary good. Mm-hmm. And so I'm kind of actually interested in like, because one of the problems with training people to do psychotherapy is it's labor intensive. They got to get a client. That's a big challenge. They got to go meet with a client. That's a lot of effort from multiple people. Somebody else has to like, ideally you're going to tape the session so you can see what actually happened. And then somebody else has to watch it and like rate and then give them feedback on how they did and what they can improve, right? Like it's this big laborious kind of horrible process. But I think these AI tools actually make it like kind of ridiculously feasible. And so I'm kind of interested in, can we develop some AI training tools that can really equip people to deliver things like measurement-based care? And I still want to focus on measurement-based care, but can we actually develop some of those tools that we could deploy in graduate programs, that we could employ as continuing education? I don't know, in social work, you have to do 20 hours of CEUs, or at least it used to be that way. The state made it lower the bar now, but it's like, you know, yeah, CEUs, blah, blah, blah. What if your CEUs actually you could learn a useful new skill and get like really good clinical feedback on it, and not in front of a room with 50 people? Like that would be pretty exciting and could really move the needle, I think. One of the big problems with implementation research, I mean, I love implementation research, that's what I do, but it's like, I just told you about this cool organizational implementation strategy that made things better. Well, now, how does that get delivered? Like, are the clinics going to all pay to have their leaders go to the training? Like, are they going to pay for the time that like, so there's kind of these other barriers that come up, right? I think the biggest value of this trial is showing that the leadership does matter and the climate you create does matter, because you can do a lot with that. But anyway, so that's a rambling answer to your question. But that's kind of where I think that's what the Endowed professorship is focusing on, is can we develop some AI tools? So we'll see how that goes. Anyway, other questions? Yes.
You sort of touched on this. I'm curious about the future of loci and like sort of the implementation of the implementation.
Yeah, it's a good question. And loci is not my baby. It belongs to the co-investigators who are on our trial. So they've actually done trials now where because one of the things with loci is like, cool, we changed this organizational stuff, and this came up in our trial too, what drives a lot of what people do is money. Can I get reimbursed for doing this, or am I gonna have to pay for this on my own out of the kindness of my heart as a healthcare provider? And so they've developed a version of LOSI that works with policy level leaders as well as organizational leaders, so they've done some stuff like that. They've also experimented with like integrating LOSI into contracts. So like when Medicaid, state Medicaid is gonna contract with some agencies to provide evidence-based practice X, whatever it is, that maybe that's part of the contract is you will participate in this leadership training and your people will do this, and that's part of what you're gonna contract with us to do. So there's things like that where people have explored with it, but it's an open problem at this point, I would say. Yeah, good question.
I have a quick question. So when does implementation start, right? So as a clinical trialist, right, when do we begin to think about implementation and the start of our research, or how do we identify when it's appropriate?
Really great question, and there's a huge literature around that. This is a hybrid type 3 effectiveness implementation trial. I didn't tell you that, because like, So, but that starts to get at this issue of like, when does implementation start? And if you're a clinical trialist and or developing a clinical intervention and you want it someday to be used in the real world, when do you start thinking about, all right, I need to make sure people can actually do this? What I would argue is you should think about that from the very beginning. And there are like deployment focused treatment development models, at least in the psychotherapy literature there are. I'm sure in other literatures there are too, but so there's this idea that you should begin thinking very early on as a treatment developer about how is this actually going to get used and fit in the setting wherever I want this to ultimately be deployed. And so, and then there's this class of trials called hybrid trials, and there's hybrid type 1, 2, and 3, and they're sort of addressing combined clinical effectiveness aims with implementation aims. And so like the earliest, the hybrid type 1, you're really doing an effectiveness trial of your treatment. That's the primary aim, but you're also going to collect some data systematically about implementation. Like you're going to actually see like where did people struggle with actually delivering our cool treatment that we think is great? Or like, what were some of the barriers and facilitators that got in the way? So you can kind of think about, you can integrate those elements from sort of a systematic research standpoint early on at that. So that's a hybrid type 1. Then there's a hybrid type 2, which is where you're testing the effectiveness of a clinical intervention and the effectiveness of implementation strategies alongside. It's like the hardest thing ever to do. It's crazy. And then there's the hybrid type 3, which is where you're saying, all right, I got the evidence-based practice. It's good to go. I just need to test some strategies, but I also want to look at these clinical outcomes, right? Like I want to kind of make sure that we're actually changing service effectiveness. And so that's a hybrid type 3. You can also just do a standard implementation trial where you don't look at clinical outcomes at all. You just say, all I care about is whether or not people use this. So that's my outcomes and that's what I'm going to do. So those are kind of the spectrum and some of the thinking around that. But there's a lot of literature in that because it's really, really important. And actually, one of the things that you see, at least from my perspective in like the NIH funding announcements and stuff, is more and more you see, it's like, okay, we're not going to give you millions of dollars just to make up something that's going to sit on a shelf and never get used by anybody. Like we need stuff that people can actually deliver. And so you need to be, savvy or cognizant, aware of that in your application. Yeah, great question. Good. We're at time. That's it. You're released. You can go eat your lunch.
Yeah, a huge thanks, Dr. Williams, for a really engaging talk. Wonderful material. Just putting in a plug for next month, we'll have our last in this cycle of a grand round presentation from Dr. Ryoko Kosler, who's sitting right here amidst this, who will educate us about expanding access for perinatal mental health care in urban and rural settings. So we'll see hopefully all of you next month. Thank you all for coming. Yeah, appreciate it. That was awesome. Thank you so much. I'm not swimming in water. I don't hear it. Like I'm here, that.
Hey, have a good afternoon.
Yeah.
Bye now. So, yeah, I saw that.